Hello and welcome to another podcast. Today we're going to focus on sepsis. You may be asking, why on earth are we looking at sepsis? Everyone talks about sepsis. There's thousands of podcasts on it. Everyone has an opinion, and quite frankly it is very difficult to get your head around. But the reason it's important, especially for our demographic, is a lot of the studies and processes that are out there are associated with high-end medical facilities. And as you know, we don't work in those, so it is more important for us to be able to identify, initiate treatment quickly in order to save the patient's life. So the focus today will be going through what sepsis is as a glance, what the major principles are of sepsis, and then going through a full pathological state of what occurs in the body when someone is septic or suffering from septic shock or severe sepsis. And then finally, what our PCCM says about sepsis. What is expected of us in the management of sepsis itself. So just as a means of introduction, we'll have a quick look at what sepsis is. So sepsis is a pretty large leading cause of death. So it's the third leading cause of death in a lot of Western worlds. Okay, so it contributes for about 1 in every 2 to 3 hospital deaths. It's very expensive. Okay, some studies have suggested that it is the most expensive condition, and it is often underappreciated or under-recognised. So when people end up dying from their condition, they're often labelled as dying from pneumonia or dying from an infection, where it's in fact a septic state that has resulted in their death. Now, it's also highly well publicised that speed is important. Okay, so sepsis can progress very, very quickly. We've all heard of the horror stories of somebody getting a skin infection and then 3 to 4 hours later dying from septic shock. Now, whilst they're quite extreme cases, it can happen. So a general rule, now these statistics are a little bit old, but they're still consistent. 7.6% drop in chance of survival for every hour that antimicrobial agents aren't begun. Okay, so that is a significant drop or increase in mortality rates based on a single condition. So the bottom line about sepsis is you need to be aware that it's out there. You need to be aware of some telltale signs, and if you do suspect it based on your clinical assessment, then you need to act quickly. It is often said when dealing with sepsis that time is tissue. Okay, and every hour you delay thinking that it could be something else or thinking about a different management instead of treating sepsis, it makes it more likely that more tissue damage is going to die. And the mortality rate obviously increases the more numbers of organs fail, for lack of a better term. Now, obviously that's pretty simple to get your head around, but a lot of the protocols, and you'll see with our protocol that people get stuck on, is a lot of the early signs are very benign symptoms. So a lot of people will go, it can't be sepsis. It's only this one slight anomaly that we're finding, so it couldn't be. Now, whilst I agree, jumping on the bandwagon and giving everybody prophylactic antibiotics is a risk within itself, there needs to be a medium in the middle that sepsis is considered in ill people, and conversations are had with professionals and further investigations are put in place if sepsis is suspected. Okay, so let's start the pathway and let's have a look at what sepsis is and how it affects our body. Okay, so we're going to look at the bacterial pathophysiology, because in reality, after this particular step, the steps are very similar because it's based on our own immune responses, and bacterial infections really account for most of the septic states. But as long as you know that it can be fungal, can be parasitic, can be viral, but bacteria is the number one leading cause of sepsis. Okay, so despite the apparent difference between our gram-negatives and our gram-positive bacteria, the systemic inflammatory response for both types of pathogens are, or at least in the qualitative state, very similar. Now, the reason that's important to know is the identity of the causative organism is not often known at the onset of sepsis. and the treatment targeting the host inflammatory response needs to be rapid and beneficial regardless of what the causative agent is. So gram-negative and gram-positive bacteria initiate the disease process by different mechanisms, endotoxins versus cell wall components. However, there is an overlap in some of the inflammatory pathways. So the CD14 receptor, which is present in many human cell types, it plays a key role in initiating cellular activity by bacterial envelope components of both gram-negative and gram-positive bacteria. So despite the subtle differences in the host response to gram-positive, gram-negative pathogens, disease severity and mortality in sepsis is very similar. So in a septic patient, it's got a lot to do with our endothelial dysfunction. So it's absolutely central to the imbalance between inflammation, coagulation, and fibrinolysis. Now we'll look at each one of those in more detail, but just know that that is the main state of the septic patients, is our endothelial dysfunction. So other pathophysiological mechanisms, including nitrous oxides and mitochondrial dysfunctions, may also be involved in this disease process, but it's the overall loss of homeostasis in sepsis patients that often and may lead to the organ dysfunction. So there's the overview, and we'll now look at the process in I'll say a little bit more detail. So starting right at the top, the stimulation of the host immune response by toxins caused by the inflammatory response can lead to this endothelial damage. So a little bit more detail is pro-inflammatory cytokines such as your trauma necrotizing factor, or TFNs, and your interleukins, which is what's denoted as that IL number symbol that you'll see on the screen, are released in response to an infectious state. Now the aim of it, the normal aim of it, is that it destroys the damaged tissues and promotes that wound healing. So normally these anti-inflammatory mediators are subsequently released to regulate the inflammatory response and restore homeostasis. So they're a good thing. So the body's initial response is to protect release for these pro-inflammatory mediators to ensure the effects of the pro-inflammatory mediators do not become disruptives. So the body launches a compensatory anti-inflammatory mediators which deregulates or downregulates the initiating pro-inflammatory response. So what that means is it's a normal state of getting the pro-inflammatory mediators in order to aid in repair, but because it's associated with breaking down of tissue or damaged tissue to aid in healing, we have these dampening agents called anti-inflammatory mediators that will turn off your pro-inflammatory mediators, and make sure they don't completely destroy the body. Now, in sepsis, the body loses its ability to regulate the balance between pro-inflammatory cytokines and anti-inflammatory mediator release. So this loss of immune regulation first leads to excessive inflammation, which is called your systemic inflammatory response syndrome, or SIRS, and then to excessive immunosuppression, which is known as your compensatory anti-inflammatory response syndrome, or CARS, in the attempt to restore homeostasis. So CARS can result in secondary infections due to the loss, the excessive immunosuppressants, which can cause further complications and a start of a new cycle of unbalanced immune response. Now this continuing out of balance, if you will, response for the immunomodulating system can lead to your acute organ dysfunction and eventually organ failure, which can obviously lead to death. So multiple organ dysfunction syndrome, or MODS, is considered to be the final result of severe, persistent, or generalized inflammation. So from there, you're in this state of out of regulation, and your body's starting to basically produce a huge amount of inflammatory mediators and lowering your immune response. Okay, now from that, the inflammation goes on to cause other functions or other dysfunctions associated with the endothelial itself. So although this inflammation is generally an essential host response, okay, it's absolutely needed, it's the excessive levels of these pro-inflammatory cytokines that can lead to systemic endothelial damage, and high levels of anti-inflammatory mediators that can lead to the immune suppression. So in sepsis, the imbalance between these two will actually result in stimulated coagulation response, inhibitory anticoagulation response, and inhibited fibrinolytic response. Now these processes lead to endothelial damage, a loss of equilibrium between coagulation and fibrinolytic mechanisms as a pro-coagulant state begins to develop. Thromboses may form in the microvascular, especially in severe sepsis, and the condition may progress on to, again, organ dysfunction. This is what causes your organ dysfunction. Now, having a really close look at that endothelial wall, because it plays such a massive key role in maintaining homeostasis. Okay, a lot of people don't give it a lot of credit, but the endothelial wall is responsible for a lot of pathological states and also your body's natural maintenance of homeostasis. So during your inflammatory response, the endothelial cells activate, which causes overall vasodilation, which allows leukocytes to access the infection site. And normally the endothelial wound downregulates these initial pro-inflammatory response by expressing those anti-inflammatories and anticoagulant mediators. Okay, but in sepsis, this regulatory function of the endothelial fails. Okay, so what's normally supposed to happen ends up failing, which leads to excessive vasodilation, which is the cause of your hyperperfusion and generalized tissue damage. Okay, but it also causes additional inappropriate cytokine responses. Now, the damage to the endothelial loses its homeostatic balance and becomes pro-coagulant. Okay, so it has more ability in the region to clot. So the endothelial is an extremely dynamic participant in a lot of the cellular and organ function. So through the expression of surface proteins and soluble mediators, the endothelial plays an important role in maintaining that equilibrium between coagulation and fibrinolysis. So the dearrangement of these normal functions contributes to the systemic inflammation. Okay, so it is the damage to the endothelial that exacerbates this inflammatory response. Now this deregulation leads to DIC, so disseminated intravascular coagulopathy. Okay, so because of this widespread endothelial destruction, you'll end up having widespread clotting being caused in the microvascular. So you have an increased risk of bleeding, increased risk of forming thrombosis, tissue necrosis, and microthrombi, which obviously blocks off blood flow to organs, which leads to organ failure. Okay, you also have a widespread use of your clotting factors, so your platelets, clotting factors, and fibrogen will be used up. So overall, a person in severe sepsis has an increased risk of bleeding, okay, either going to surgery or additional wounds, and they also have an increased risk of thrombosis as well. Now, all of these states, as mentioned, okay, looking at them all in a summary, it's the presence of an infection that causes a normal host response of your pro-inflammatory mediators, which is regulated by your anti-inflammatory mediators. If the host response gets too great, then you get a deregulation of these two factors. Now, coupling this with your leukocyte activity, okay, which is obviously what brings on your more vasodilatory responses, increase more cytokines, pyruvates, which gives you the temperature, it leads to tissue injury, okay, because leukocytes will do what leukocytes do, and unless they're regulated by coenzymes or cytokines, they will start destroying tissue because there's nothing stopping them. So you'll end up getting tissue damage that way. Now, this endothelial dysfunction, which is caused by the tissue injury, gives us a state where we have a inhibition of fibrinolysis. Okay, so there's nothing really breaking down clots, and a state where clots are more likely to form. Okay, because the endothelial dysfunction has caused collagen fibers to be released into the vascula, platelets connect to it, start the clotting cascade, and then there's the inhibition or the inability to break that down because you don't have the fibrinolysis factors. So this leads to your microvascular coagulation with thrombosis, which again leads to tissue injury. Now, this tissue injury is obviously going to lead to organ dysfunction by a mixture of profound inflammation, loss of perfusion due to vasodilation, and also microthrombi, which stops blood flow going into the organ. Now, couple all this, we also have mitochondrial dysfunction. So the mitochondria have the inability to produce the energy required in order to aid in healing, which just exacerbates organ dysfunction. Now, once we get to the point of severe sepsis and septic shock, it's this organ dysfunction that travels through the body that will lead to your death. Okay, so quite a complicated state, as you can appreciate. There's a lot of moving parts and a lot of complementary moving parts, but as long as you take away that it starts with an infection, that the lack of regulation and overstimulation of certain parts of your body, that will in turn lead to further destruction, problems with your clotting, organ dysfunction, and death. Okay, so moving away from the pathogenesis, we'll look at the systemic inflammatory response syndrome itself. Okay, so it was invented a while ago. We're talking 1991 is when it first came out, and it was made by the American College of Chest Physicians and the Society of Critical Care Medicine. And it was done at a consensus conference. And what they did is they developed a clear definition of the disease continuum. Okay, now the groups came up with 3 terms, which was sepsis, severe sepsis, and septic shock. Conference also defined the initial SEERS. Okay, and then you have your SEERS criteria, which is the evaluation of abnormalities associated with temperature, heart rate, rest rate, and white blood cell count. Okay, so SEERS represents a clinical presentation of widespread inflammation that results from a variety of infections. As you can see, bacteria, fungi, parasites, viruses, and others like plasmodiums, things like that. But the reason it comes under a lot of conjecture and a lot of reason why huge amounts of hospitals out there have additional protocols based on trends and presentations is because there's a lot of other conditions, a lot of other states that also causes SEERS. Okay, so it's not just sepsis that you'll actually get systemic inflammatory response or symptoms of inflammatory response, which is where the water gets really murky. Okay, so from here we're going to talk about the PCCM. Okay, and maybe hypothesize some of the reasons why they've come up with these particular criteria as opposed to following others. Okay, so first of all, having a look at the sepsis criteria for the PCCM, we start with obviously step 1. Now, when a patient comes to you presenting with an illness, now you need to be very clear that this is for a patient with an illness. Okay, not a patient who's been involved in some sort of kinetic trauma, not a patient who is suffering from heat, or anything like that. It is literally a patient who comes to you with an illness. Okay, first thing to do is to look for any of these particular points. Now, the points written in the right hand column is for our demographics, so anyone over the age of 16. So we're looking for a low BP, less than 90. Okay, now because you're not going to know what their normal is necessarily, especially in the field, you're just going to go for the less of systolic at 90. Okay, also quantifies lactate. Now, if you're able to take it, fantastic. If the treatment team actually takes the ISAT out, fantastic. But integs, you're not going to know. Okay, Other big telltale signs is you're looking for those non-blanching rashes. Okay, usually indicative with your shingles, things like that. Look for those non-blanching rashes, but also look for their general appearance. If they're cyanotic or they look ashen, okay, that's a big telltale sign. Now, respirate's a quite difficult one, okay, and usually the reason why a lot of people don't initially call is just for a high respirate. So if someone has a respirate over 25, PCCSM says that is a criteria that you need to start investigating sepsis, okay, that they have sepsis, at least initially until proven otherwise. Now the reason for that is you've got to take the variables out of it, okay, so like I said, no kinetic trauma. You're talking about a person presenting with an illness and the respirate's over 25, okay, then you bring it in. Couple that with the need of oxygen in order to maintain an SpO2 over 92, then you start getting more of a picture that this is definitely starting to look like sepsis. Heart rate of over 130 is another criteria which we need to call, and any drop in GCS. In regards to urinary output, what they're looking at is a state of hyperperfusion. So if someone hasn't passed any urine in 18 hours, that's a pretty good indication that they're underperfused. Their kidneys are no longer creating urine, therefore they're underperfused. So it's a good telltale sign, early sign of sepsis. Now, recent chemotherapy for our demographics, they're not going to be in the field. Okay, so, but just be aware that that is one. Now, the idea of these particular criteria is if you have a patient presenting to you with an illness and they have any one of these signs, then you need to call the MO and hand over the patient's details to the MO. Okay, which brings us to the second criteria. So as I said, any features of severe illness, which is any of the aboves, then assume the patient has sepsis until proven otherwise. Contact the MO. If the MO agrees, start treatment straight away. If they don't have any of those severe ones, then you can start looking at these other ones, which is like they're on the borderline for a lot of it, and then we start bringing in temperatures as well. Okay, so if they have a temperature over 38.5 or under 35.5, then you can consider that they have it, and then still hand over to the MO, and then go from there. So if you are concerned about their mental health status, okay, if they haven't passed urine in 12 hours, or you've noticed that there's an acute deterioration, okay, so basically means if you're worried about the patient that they could have sepsis, then you hand over to the MO, but you just mention a little bit more on the history and the examination, which gives you an idea, which hands over your assessment of why you think this person could have sepsis. First criteria, don't really have a choice when you're dealing with this protocol. You must call and you must verbalise it and then get verbal orders from there, as in what to do. Anything in this criteria, it's more of a conversation, more of a peace of mind, more of bouncing ideas off in order to provide the best treatment for the patient. Okay, if they don't have any of these symptoms, then yeah, you can finish your history, examination, and then realistically you can hand over when you get back. Unless you want to give medication or anything like that, then obviously you're going to need to call the doctor at that stage. Okay, so as you can see, pretty clear-cut criteria. Okay, and you need to be aware of these because since we're practicing under the PCCM, you are expected to follow these particular protocols and consult the MO if any of these signs are found in an ill patient. Okay, so we'll move on to step 3 and we'll go through what is expected at each level of our care continuum for these patients. Okay, so we'll start with the management from an integral perspective. So based on the criteria we just spoke about, you're already going to have a consultation with the MO, which basically decides that you agree that it's sepsis or septic shock, so you're going to start the management. On top of that management, you need to organise evacuation as early as possible. The reason for that is best management of sepsis is not done in the field and it's not done pre-hospital. You need blood cultures, you need to do investigations in order to narrow down where the infection is coming from, and it often requires ongoing management and sometimes intensive care. So whilst you're waiting for the evac to come along, things you can do is make sure you maintain that oxygen saturation level. You want to give the body as much oxygen as it needs in order to compensate for any mitochondrial dysfunction that may have occurred. So the goal is always to maintain it above that 94%. So if it's already above 94%, you don't give any oxygen at all. But if it's less than that, you bump it up just enough so it's on that 94. You don't want to do too much, because obviously too much oxygen can obviously add to that nitrous oxide vasodilatory response that makes septic shock that little bit worse. Intravenous cannulation is an absolute must. You have to get lines in, and you've got to get them in early. So you want to go for two, one for fluids and antibiotics, other one for blood, and also it's great to have a backup. If you cannot get intravenous cannulation, then it's best to get intraosseous. Whilst the antibiotics can be given intramuscularly, quite often the patients will need to have blood withdrawn, and they'll need to have ongoing fluid resuscitation as well. So go the IO if the intravenous cannulation doesn't work. Now, based on initial observations, you'll have a good set of vital signs. Now, if there's an indication that the patient needs fluids, then you'll give a 500 ml bolus, and you'll repeat that as needed. But there is a limit to repeating the 500 mils. Basically, if you work on the premise of 30 mils per kilo is the maximum amount you'll give, is a good place to start. Now, the reason for that is if you picture what we've spoken about, when someone's in septic and septic shock, they're suffering from profound vasodilation. So every capillary bed is now open and all vessels are basically leaky and dilated. So if you load a whole bunch of fluid into these people, the permeability of these vessels have increased, so the fluid will transition into that third space and can cause more problems. So there's a few patients out there that are what's known as non-responsive to fluid resuscitation, which gives rise to many studies and practices in tertiary facilities favouring vasopressors over the fluid resuscitation. So you give as much as you need to, you be careful not to overdo it, and it's always based on consultation. Now, other things you can do as an integ, and weigh it up if there's a treatment team nearby or not, but if you're an integ and you have no prospects of a treatment team or a prolonged evacuation to a treatment team, then you can start the antibiotics that we'll speak about next early before ultimate evacuation to a tertiary facility. You can also do a BGL, because if that is low as a result of the sepsis, or the septic shock, then you can correct that as well in order to better support the patient, especially in energy production that they're going to need. So moving on from integral, or continuing that treatment that we spoke about, once you get to a steady state, we need to start looking at things like your empirical antibiotics, continuing fluid resuscitation, and we can often entertain the idea of taking bloods. But the goal is even in a treatment team, this is not the end of this patient's evacuation. This is just a stepping stone to get a slightly more controlled environment to do better management and further investigations, but they need to continue on to that Roll 2E plus or that further facility itself. So with your ISTAT, there's certain bloods that are definitely needed when you're dealing with sepsis and septic shock. One of those is lactate. The other one is obviously your venous blood gas, and your UNEs can help too. So if you take an EC4 and an EC8, that will give you a good idea of what lactate is, what your UNEs are, and also your general venous blood gas as well, just to give you an indication. Now, in regards to antibiotics, the empirical treatment for people over the age of 16 is you've got to give the beta-lactam, which is great for your gram positives, and that's 2 grams of flucloxacillin. And that's pushed over 6 to 8 minutes is the ideal amount of time to push 2 grams of flucloxacillin. The other thing that you give on top of the beta-lactam is an aminoglycoside. Now, the protocols recommend gentamicin. Now, gentamicin is either 5 milligrams per kilo or 7 milligrams per kilo, depending if it's sepsis or septic shock. But it is calculated off ideal body weight with a max amount of 500 or 700, depending if you went for the 5 or 7. Now, the calculation is difficult to figure out. It does take time. So I recommend you go back and have a look at the lesson I did on gentamicin in order to get a better understanding of how that is best administered. Now, to make things a little bit more complicated with those two, is you want to give the antibiotic that has the shortest infusion time. Now, technically, gentamicin has an infusion time of 3 to 5 minutes, whereas flucloxacillin is 6 to 8. However, gentamicin can be difficult to calculate and can take time to draw up and get the right dose. If that's the case, and especially if you're working by yourself, it's often a good idea to give the flucloxacillin first and maybe hand it over to another clinician whilst you get the gentamicin ready and the dose perfect. Okay, you want to get that dose spot on. Now, gentamicin cannot be mixed with beta-lactams. Okay, it absolutely is completely incompatible. So, regardless of which way you give it, either gent or fluclox first, you have to push it into the line and then use an alternate line or really flush the line before giving the other antibiotic. Now, if you suspect that the person has meningitis, and realistically, if meningitis can't be excluded, so you have that positive meningeal signs, then you want to give your 2 grams of ceftriaxone as well, and your 10 milligrams of dexamethasone. Now, if you're giving dexamethasone, that has to be given with the first antibiotic, fluclox or gentamicin. And to complicate matters worse is if you're in an environment or have a certain demographic where MRSA is suspected, you give all the above antibiotics that we spoke about, and you give vancomycin, which is calculated to be 30 milligrams per kilo of the actual body weight, not ideal body weight, like gentamicin. Okay, so as you can see, the antibiotic regime is quite complicated, so it is highly recommended that as an integ and working in the treatment team, your sepsis protocol is something that you practice, something that you understand and you communicate with your team in order to have a full understanding of what the management is all about. Now, when the patient moves on from the treatment team to its tertiary facility, either in a Role 2E or an established tertiary facility, then the management will continue, and we'll discuss that next. If the rolls up to the Role 2 echo, big hospital in the ground, from there then we can actually take blood cultures. Now, whether or not you take path cultures or your aerobic or anaerobic cultures is going to be based on the pathology that you have with you. A lot of the times they won't, okay, because it takes time in order to run those tests, and realistically you sort of want them on to a high facility beforehand. But you can definitely take your lactate, full blood count, UNEs, LFTs, lipase, blood gas, and if you're dealing with severe, then you take their coagulation screens as well. On top of that, you look at the urinalysis. You get a midstream urine looking for MCS because you're starting to rule out and starting to narrow down that site of infection. The goal is you want to find that infectious site so then you can narrow down the probability of spectrum in which antibiotics you're going to give. Okay, monitoring is very important. Okay, you want to take lactate initially and then 4 to 6 hourly. You want to aim for less than 2 millimoles per litre. And you want to monitor the urinary output, and you're aiming for 1 milligram per kilo. Now, 0.5 mils per kilo is fine, but you always want to aim for 1 mil initially, because if you fall short, you're going to be within the range of 0.5, and then you can titrate down. It's very hard to titrate up if you don't quite meet that 0.5 output, and then you've kept that person in that hyperperfused state whilst you're trying to get up to that 0.5. Okay, in the hospitals and with the doctors and the treatment team, it's whichever way you want to do it, but for certain patients you want to consider your vasopressors. Okay, we're not going to go into those in this lesson, okay, but consider vasopressors. There's a lot of literature out there that pushes towards vasopressors over your fluid resuscitation for your sepsis and septic shock. Okay, bottom line is this person, if they are in a septic state, they will often need to go to ICU in order to continue their monitoring and narrow down the causative agent until it is cured. Okay, from there, the patient's journey doesn't end statistically when they're discharged. Okay, so post-septic syndromes are a big thing, and they result in a lot of problems. Okay, as you can see, you've got neuromuscular weakness, chronic pain, but then you can also get states where you have the brain can be affected. So patients can have depression, cognitive impairment, and also suffer from post-traumatic stress disorder after, especially if they visit or spend time in the ICU. Okay, so recent study, 22% of cases of people who went to the ICU and they survived sepsis can end up with post-traumatic stress disorder, okay, which is pretty alarming first time I read that. Okay, on top of that, you can also have a lot of sleep disturbances, general tiredness. So the bottom line is the patients that we treat with sepsis will most likely need ongoing management within the military after their sepsis has been dealt with. Okay, so just something to keep in the back of your mind. And because we are all clinicians, there are things that we can do in order to prevent sepsis from our state. Okay, so nosocomial septic states are unfortunately quite common. So if you are working in hospitals, okay, role 2, treatment team, anything like that, hand washing. Very important. Treatment team should always go out with a sink and always have soap with the water. Okay, chemicals of subpar, soap and water is the way to go. If you are and you need to do invasive procedures, especially in a tent, really weigh it up and use absolute perfect aseptic technique every single time. Make sure everyone gets vaccination for the flu when they can, and then reassess. Always reassess the patient if they're staying in and get those cultures back, and then if you can narrow down the regime of antibiotics, you really want to narrow the spectrum and make sure that you're giving the antibiotic that is the best type for that particular pathogen. Okay, if you're given a regime of antibiotics that you need to give the patient, like on a ward, make sure you give them the antibiotics at the correct time as well. Okay, so that will end the lesson on sepsis. Hope you got something out of it. Like I said, overview of the pathogenesis, and then a look at what the PCCM states. Now, you may be thinking that the PCCM's criteria is a little bit broad. It's a little bit open, okay? And to tell you the truth, compared to others, it is. Okay, it is quite broad and open. But you've got to remember that it is written for remote care. So in order for that patient to get to a facility that can best treat sepsis, especially severe sepsis and septic shock, it's going to take a long time for evacuation. So because of that extended period of time, you need to be able to identify sepsis early in order to get ahead of it. Because if you don't learn anything from this lesson, the take home is that time is tissue. The longer you do not treat sepsis, the more likely someone is going to die or have permanent impairment. Okay, so until next time, take care.